All right, everyone. Thank you so much for joining today's Tuesday Topics. Why choose PEEP and how do I choose PEEP? Really thinking about lung recruitment, lung compliance, the stiff lung. When do we make decisions about how to add PEEP? When is enough PEEP enough? And is PEEP really the therapeutic intervention that we should be considering in today's ARDS or non-compliant lung process? So for any of you who have joined me before, you know this is not really a basic class. Hopefully we have some understanding of ventilatory mechanics. Spent a lot of time over the past 2 years talking about ventilation, but today I'm really going to be focused on very specific methodologies for lung recruitment, for opening the lung, promoting better gas exchange, and also for the discussion of something that actually has been evolving in the literature for about the last 3 years, and that is the evaluation of driving pressure. So we're going to talk about all those things in the short time that we have together. For those of you who are online and in real time, I just want to remind you that I am not able to silence you automatically. So if you wouldn't mind, make sure that you're on mute. You have to mute yourself. I can go in and mute you, and I think I've already done that for everybody, but please just mute yourself when you join the presentation. It just makes it easier for everybody and it reduces any reverberation. So again, welcome to Tuesday Topics. Today, how do I choose PEEP? And choose PEEP I will when I think that the lung is not compliant. So we do have to just talk about some very basic issues. I want to remind you, whenever I talk about pressure and volume and compliance, I always use this simple graphic to just remind you that pressure is what we measure. We measure arterial blood pressure, we measure central venous pressure, intracranial pressure, intra-abdominal pressure, and we also measure airway pressure, both from a dynamic perspective when I'm flowing gas into the lung, and also from the static perspective when I've trapped gas in the lung. And I always like to remind you, when we look at pressure, you have, of course, two major components here, the component of volume and the component of compliance. Now, volume is a really important thing for us to remember when we're talking about lung function. And please, everyone, when you join, please mute yourself because you're not automatically muted and you might be having a sideways conversation, perfectly fine, but we don't want to actually be part of that conversation. Thank you. I guess I probably have to check and see who's not muted. So let me just look. It looks like everybody muted themselves. Good job. Thank you so much for doing that. All right. So when we look at volume, what you want to remember is when we're talking about lung ventilation, we've intubated you. We have a target of volume. That's assist control volume ventilation. Our target is volume. We're going to put a certain amount of volume into that chamber. And what's really important to remember is that when the chamber is compliant, a significant amount of volume, that would be 8 to 10 mLs per kg of predicted body weight, 8 to 10 mLs of volume per kg shouldn't really yield a high pressure if the lung is compliant. But what we often see, we're at the bedside, our peak inspiratory pressures are high, and that may be because the airways are not clear, the patient might be biting the tube, there might be fluid in the tubing, but it could also be because the lung itself is not compliant. And that's really the focus of our talk today, is the lung that is not compliant. When the lung is not compliant, what that means is a significant amount of alveoli are not open, they are not recruited, they are not participating in gas exchange, they are collapsed. When we have collapsed alveoli, the lung becomes non-compliant. Very small changes in volume will yield a relatively big impact on the pressure. Now, it's really important to remember we don't give patients pressure. We give volume into a compliant or non-compliant chamber. And in this case, we're talking about the lung. So remember, standard volume that we use today is 6 to 8 mLs per kg of predicted body weight. And we give that volume into a lung, whether it is compliant or non-compliant. We traditionally will start with 6 to 8 mLs per kg of predicted body weight. Now, it really isn't about weight at all. Those of us who've been working with ventilation for a while know it's not really about weight. Predicted body weight is actually about the size of your thoracic cavity. Now, this is really critically important. You don't have to memorize anything on your ventilator. Typically, you'll have a sheet that says, for a male who is this tall, you should have them on this much tidal volume if you're doing 6 mLs per kg predicted body weight or 8 mLs per kg of predicted body weight. But you too can actually look this up by using the ARDSNet, ARDSNET space PBW, predicted body weight calculator, and you will look at a PDF that tells you exactly how much volume your patient should be on based on their gender and based on their height. It has really nothing to do with weight. Now, why this is so important is because this is really going to drive our perspective of what we're going to do with patients who are actually presenting with some physiologic stress or strain when we're delivering a tidal volume into the lung. So remember, we typically are going to start with 6 to 8 mLs per kg of predicted body weight. That's a really safe level of volume that we're going to push into the lung, and we're going to measure the corresponding pressure, and that measurement of the corresponding pressure is going to give us some idea about the lung compliance. Not a complete idea, but a partial idea. So we always want to remind ourselves that lung is normally compliant. We can put pretty big volumes in there. We could do 8 to 10 to 12 mLs per kg. We never do that now, but you could do that in a compliant lung. And for most of us in the ICU, the lung that we see that is compliant is typically the patient who has chronic obstructive pulmonary disease and emphysema. They have a very compliant lung because the problem for their lung is that they can't recoil and exhale their gas. So you could give them a bigger volume with a relatively low pressure because the lung is very compliant. But most of us in the ICU and the ECC and places where we're seeing patients who have lung injury and lung dysfunction is that they typically have a non-compliant lung. That non-compliant lung is a resistant chamber now. So small amounts of volume into that non-compliant chamber, that resistant chamber, is going to yield a very high pressure. Now, when we go and we look at our ventilator, the first thing that we see on the very top row of information is peak inspiratory pressure. And that's about the amount of pressure that is generated when we flow gas into the lung across the ET tube, the conducting airways, to the alveoli, and also considering the chest wall dynamics. So lots of things affect that, and it's really important for us to appreciate that. But what I want you to remember is that we have always been looking for better methodologies to actually look at alveolar compliance or alveolar recruitment. So we're going to talk about that. That's known as the plateau pressure. We're going to look at it. We're going to talk about how to measure it. We're going to talk about how to utilize it. But what I want to remind you about is the plateau pressure is really dependent on how many alveoli you have recruited. So when you've recruited a small amount of alveoli, but you've given a stable tidal volume, and again, 6 to 8 mLs per kg, you're going to have a higher plateau pressure. Now, I have to measure that. That's not displayed on the screen until I do a measurement. I'm going to have a higher plateau pressure. The less alveoli are recruited, the higher the plateau pressure. So typically what we're going to do is we're going to choose PEEP. We're going to choose PEEP to help open up the alveoli. And as we increase the PEEP, your plateau pressure will also increase. But what's really important is something that we call the drive pressure, which is plateau pressure minus PEEP. And that actually gives us an indication of how much stress or strain we are promoting in the non-compliant lung. Okay. Wow. This is so incredible to be able to talk about this because I rarely talk about drive pressure, and it's such an important component of understanding when I'm talking about a non-compliant lung. So really our focus will be on that lung compliance, on that plateau pressure, on the introduction of PEEP and trying to open the lung, and how we're going to actually evaluate the stress or strain on the already open lung, the already functional lung, which we have to actually get past in order to recruit the collapsed alveoli, not the consolidated alveoli. I'm not going to be able to recruit them. I have consolidation, but on the collapsed alveoli. And that's really what my goal is in adding PEEP. So first, let's just remind ourselves about lung compliance. Lung compliance, there's no muscles at all in the alveoli. Air passively moves in and out of the lung in response to pressure gradients. So I'm applying flow of gas to a target of volume or a target of pressure, yielding a higher pressure than the pressure that's in the alveoli. Basically, the pressure in the alveoli is equal to 0. So if I'm giving you volume or flow to a pressure of 25 or 30, that's a pressure gradient that supports pushing the gas into the alveoli. There's a lot of things that resist the opening of the lung. First of all, the tension in the alveoli, that's called the surface tension, that's exhibited at the lining of the alveoli, is actually the tension in the alveoli that is generated when there is fluid outside, blood in the pulmonary vessels, or extravascular fluid, all supporting and pushing the alveoli to collapse. That's called surface tension. And we all know that along the alveolar wall, you actually produce surfactant, which opposes the collapsing of the alveoli. Now, that surfactant is something that's present in a healthy lung. But once we have some lung injury and lung inflammation, we can lose surfactant production, and therefore the alveoli are going to have a higher tendency to collapse. Extravascular fluid or debris, and that debris would be inflammatory mediators and neutrophils and other products. Extravascular, meaning it's moved out of the vessel and it's now surrounding the alveoli, it's also going to support alveolar collapse. So now I've got two things in a sick patient, perhaps a patient who's septic, a patient who's aspirated, a patient who has direct injury to the lung. I have decreased surfactant production, so the alveoli collapses. I have extravascular fluid or debris, and I see it on the chest x-ray as whiteout, and the alveoli has collapsed. And it's also really important just to remind ourselves that the natural inclination of the alveoli is to collapse. It's just the natural tendency. Surfactant opposes that collapse. Gas in the alveoli opposes that collapse. But in the condition where a patient is critically ill, they have lung inflammation, they have vascular inflammation, they have destruction of the endothelial barrier, and fluid and particle has moved outside of the endothelial barrier of the vessel and is now surrounding the alveoli collapse. Now, when the alveoli collapse, that means gas isn't there. You still have blood flow by, but you don't have any gas in the alveoli. This is actually called intrapulmonary shunt. And when we talk about ARDS, when we talk about atelectasis, we are talking about a patient who actually has some component of shunt. Gas is not there, blood is there. So I always say shunt in the lung. So we're only talking about the lung right now. Blood is there, but gas is not. And our purpose is we want to open your alveoli so that we can promote better gas exchange and the matching of your ventilation, your alveolar ventilation, to your pulmonary perfusion. That's called the VQ. So really, really important. Now, at the bedside, there is something known as a volume pressure scalar. That's what it's called. You can ask your therapist to show it to you. It requires a lot of interpretation, but I want to look at it in a manual drawing because it's so easy to interpret when you're doing a manual drawing and a very straightforward drawing, that what we're looking at is airway pressure and volume. So volume and pressure. And typically, as you breathe in, what you see is gas flows into the lung. As gas flows into an open lung, the pressure increases until you reach the peak, and then you exhale. Gas goes in, reaches the peak, and you exhale. And it gives us this football-like appearance, which you will probably never see because this is a nice, normal, compliant lung. Now, what that means is as soon as gas is flowing into the lung, it's getting distributed right down to the alveoli. There's no resistance. The alveoli are compliant. Oh my gosh, we hope and pray for that in our patients, but that's not normally what we see. What we normally see is patients with a decreased compliance. Now, again, interpreting these scalars, this is very sophisticated. Many respiratory therapists have discomfort with this. I am not making you a respiratory therapist by any means. I don't have the capability. We don't have the time. But what I want you to appreciate is as you look down here, you see that gas flows in. And finally, the lung opens, but we're already a third of the way through our inspiration before the lung opens, because in the beginning, that gas flow is just about getting the lung open. That's really important. So it's sort of like, I always remind myself about a balloon I buy at a balloon store. I can blow that up with ease. It's really simple. But when I buy a balloon in a package of 100 from Kroger, I have to blow really, really hard trying to get that balloon to inflate. And this is what I'm going to remind you about here, is that when you have a non-compliant lung, a good portion of your breath is wasted on trying to get the lung open. When the lung finally opens, what you see is a takeoff of the flow of gas into the lung. But you can see that football, that normal football, which was the normal lung, now has shifted down and to the right, and a large portion of the breath is actually wasted because we're trying to open the lung. Now, where I put this little arrow is what I'm going to call the low inflection point. That's the point at which the lung is open, and now I'm flowing gas into the lung. What that means is if I was really skilled, or if I'm working with a therapist who is really skilled, we look at that and we say, your lung opens at 18 of pressure. That means I'm going to set your PEEP at 18. That's when the lung is open. And that means that the breath is going to shift all the way over here. And now I'm going to flow my gas into an open lung with an opening pressure of 18, but I'm starting at the opening pressure instead of requiring the breath to open the lung. So you can really appreciate that. I want to convert that Kroger balloon to a fancy balloon store balloon. I need that lung to be open so that all breath actually reaches the only place where it really matters, and that's the alveoli. So that's called the low inflection point. We can set that by looking at volume pressure loops, but again, that's pretty sophisticated. It requires somebody who's very skilled, and patients never look like this. Their scalars never look like this. Now, in a person who has a very beautifully compliant, non-resistant lung, like a COPD lung or a really healthy lung, you're going to see again that the breath takes off as soon as the gas starts to flow, and it reaches the peak at a very low pressure. Now, peak is what we measure at the peak of gas flow that tells us about the resistance and compliance of the lung. So it's a very important measurement that we're going to make when we're evaluating our patient. So now I just want to bring that to kind of a head here, where I'm saying I'm flowing gas into the lung. The takeoff of gas flow is what we call the lower inflection point, and that's the minimum pressure required to maintain your alveoli as open. For most patients, that isn't going to be 8. It probably isn't even 10. The sicker the patient, typically the higher the low inflection point is, which means the higher the PEEP is going to be in order to open the lung. Gas flows in and flows in and flows in, but it also can over-distend the lung because I'm giving too much gas into the functional lung, too much flow of gas into the functional lung. And what I'm going to see in that scalar again is this picture. It's called a beaking picture that shows us that we've over-distended. What we're always looking for, and we're not doing it ourselves, we're working with the respiratory therapist, we're working with the pulmonologist, we're always trying to take advantage of this at the bedside when the respiratory therapist and pulmonologist are there, really trying to look at these scalars to get experience. We're not determining this ourselves, but what we're going to shoot for is what's known as the sweet spot, which means we are open without over-distending. If the lung is open without over-distending, the flow of gas, the volume that you're delivering or the flow that you're delivering is going to be maximized. That means you're going to have better gas exchange. And you're not going to over-distend, which means that hopefully you're not going to injure the functional lung. So we're always looking for this sweet spot. And what I found is that in general, we intubate a patient, we put them on 5 of PEEP, or we put them on 8 of PEEP, and we kind of hope that that's going to be okay. But we're not really looking at whether that is the right measure to open the lung in order to provide better gas exchange. And again, I am not asking anyone on this call to be the person to make that absolute decision. You're always going to make that with an expert, and that will be your respiratory therapist. And the more expert the therapist, the more likely they're going to be happy for you to look at these volume pressure scalars or loops and graphs in order to determine, how do I optimally open the lung and how do I protect from overdistension? So really important to appreciate that most of us come to the bedside, we are just accepting of whatever the patient's been set on, and we're hoping that the blood gas looks good, but that isn't enough. We really have to look at whether or not we're able to optimize our patient's lung function. We're evaluating that patient, we're looking at information, and of course, we always want to pay attention when the therapist is there or the pulmonologist is there, and even better, if they're both there together. And remember, we're going to shoot for the sweet spot. We're going to set PEEP at a point where the lung is now maintained open, so the gas flow goes straight to the alveoli without overdistending, meaning that once I've opened alveoli or in the functional lung, if I overdistend those alveoli, I'm going to cause a stress injury and a shearing injury, and that's going to make my patient much worse. It really is complex, and we really want to treat it with the respect that it deserves. Okay, so in general, we're going to set PEEP close to either the mean airway pressure or the PEEP plateau pressure. Okay, now we're going to look at what those are. We're going to look at them on a ventilator. We're going to look at what the meaning of that is. Really important for us to appreciate this and to understand. But what we actually are going to do is on our ventilator, we press an inspiratory hold button that traps gas in the lung and distributes it across the functional lung surface. The larger the functional lung surface, the smaller the amount of volume in each individual alveoli, and the lower the pressure. The more lung surface you have, the more alveoli are open. When I trap gas there, what I'm going to see is a lower pressure because I've got a big compartment. But when I have a dysfunctional lung and half or 3/4 of the lung is de-recruited, some of it is consolidated, some of it is fluid overloaded, some of it is de-recruited, I now have a much smaller lung surface, same tidal volume, much smaller lung surface. So when I trap gas in the lung, it's distributed to that much smaller lung called the baby lung or the small lung, and that's going to yield a much higher pressure. Now, historically, we've looked at the PEEP plateau, and again, I'm going to show you what that is. I'm going to show you how to do it. I'm going to talk about what it means again and again and again. But historically, we've used the measurement of the PEEP plateau pressure to actually tell us where we need to set our PEEP. Now, remember, the first thing I talked about was look at the graphic and look at low inflection point. When do you have takeoff of gas flow into the lung? Low inflection point is the PEEP you want to set. Then we're going to look at PEEP plateau pressure, and we're going to think about how that relates to the PEEP that I'm going to set. But then I'm also going to talk about driving pressure, which is a little bit of a different concept, especially for people who are experienced. We're looking at patients thinking about PEEP, utilizing PEEP to recruit the lung and to promote better gas exchange. Okay, so normal PEEP, physiologic PEEP is 5 to 8 centimeters of water pressure, but we can go as high as 25 or 30 of PEEP just in standard ventilation. And when we're making some measures, we might even go higher than that. Now, we're not going to sustain our patients on PEEPs higher than 30. That's very traumatic. It's very traumatic for the lung. It's very traumatic for us as the provider. We're very uncomfortable with those higher levels of PEEP, and they are not without consequences. So I'm not saying to you, go back to your place, get patients on 30 of PEEP. What I am saying is, don't assume that 5 to 8 of PEEP opens the lung of somebody who has lost lung compliance. You have to make specific measures to know that, and that's how we choose PEEP. Okay, so now we're going to go back to that low inflection point and then the upper limit inflection point. So you see where we're going to take off here. This low inflection point is right around 8. And that's when we actually see that we're going to recruit the lung. You can see at lower PEEP, that's where you are over here, much of the lung is not open. At higher PEEP, a good percent of the lung is open. And at even higher PEEP, so this is PEEP of 30 to 35, what you have is overdistension of the lung. Now, you don't know that from this lung CT. You know that from looking at that volume pressure graphic. Remember that beak tells us that we're overdistended. So we really want to stop recruiting at about this level. And we want to start recruiting at about this level, the lower inflection point. We want to stop at the upper inflection point, and we don't want to overdistend. But our purpose with PEEP is to open the lung so a lower percent of FiO2 will yield a really great oxygen exchange. That's our purpose. That's what we're trying to do, is to promote better oxygenation of the blood with the lowest possible FiO2 and with the PEEP that is specifically designed to open the lung without causing injury. And that's really the goal. That's a really straightforward goal. This is a great YouTube video, but I think I'm probably not going to actually be able to connect to it because I think I forgot to put it into hyperlink, so sorry. But that's okay. I just want to remind you that when you come to the bedside of a patient who's intubated on a ventilator, and this is really the only group we're talking about just now, you're going to see two types or three types of pressures. First, you're going to see the peak inspiratory pressure. That's the peak pressure as gas is flowing into the airways. So it's the ET tube, the conducting airways, the alveoli, and the chest wall. And then remember, we're going to press an inspiratory hold button, and you might not be the right person to press that. That's okay. And you should always talk to your respiratory therapist before you ever touch anything on the vent, get their blessing, get their approval. But when we press the inspiratory hold button, we trap that volume, and that volume is distributed across the functional lung. The smaller the functional lung, the higher the pressure, because the smaller the lung, the less compliant, but you're still giving a certain tidal volume, typically, again, around 6 to 8 mLs per kg of predicted body weight. So we're going to look at that plateau pressure and say, this is a great indicator to us overall about whether or not the lung is recruited, whether or not the lung is open. Okay, so now our first time to see this, okay? So when we're looking at a pressure waveform on our ventilator, gas flows in, until you get to the peak pressure. And remember, that's the ET tube, the conducting airways, the alveoli, and the chest wall. And then I press an inspiratory hold button, and that gives me what we call the PEEP plateau. And that actually looks at the relationship of the volume across all the functional alveoli, okay? Normal peak with a standard volume breath should always be less than 45, and normal plateau with the volume breath on inspiratory hold. It has to be a volume breath, can't be a pressure breath. Has to be a volume breath. So you're on AC, volume control, even just for a moment when you're making these measures. And it has to be on a vent breath. It can't be on a spontaneous breath. Has to be on a vent breath. Has to be on a volume control breath. And normal peak should be less than 45, and normal PEEP plat should be less than 25. Now that tells us, A, that the lung is accepting the volume, and B, that the alveoli are functional and open. And that's going to be a really important concept to us. So here are some basic numbers, and these are just some numbers that can be displayed on your ventilator. This is a particular ventilator. It's not a ventilator we use here at Grady. It doesn't matter. It only matters that we understand the different measures. So we start with PEEP peak. That is the peak pressure that is generated when gas is flowing down the ET tube, conducting airways to the alveoli. P mean, which is the constant pressure in the airway that actually helps to maintain alveolar opening. So P mean is very important, the mean airway pressure. Okay. And then we go down to P plateau. And P plateau is when I press that inspiratory hold button, I've trapped gas in the lung, and I get what's known as the plateau pressure, which then conveys to me alveolar recruitment. The higher the P plateau, assumably, not 100% of the time, but assumably, the less alveoli are recruited. The smaller the lung, with that gas flow, that volume that's been delivered, the smaller the lung, the higher the pressure. Now we're looking at this patient, we're saying his peak is 18, I said less than 45. His plateau is 17, I said less than 25. And his mean airway pressure, which is a combination of peak and plateau, end expiratory pressure, PEEP, that mean pressure is about keeping the lung open. And all of those numbers are normal. They all look good. Peak, plateau, mean, and the patient's on 5 of PEEP. Okay, so your patient has a nice open lung. His lung is not stiff. His lung is compliant. You're very happy. He has good gas exchange. You're on 30%, 40% FiO2, and your patient has a really beautiful PaO2 and beautiful SAT, and you feel really good about your day. You feel great when you walk into the room. You look at those pressures. That should be the first thing you look at when you look at the ventilator. What is the peak? What is the mean? What is the PEEP? You have to press an inspiratory hold button to get your PEEP plateau. Okay, so this is the standard ventilator that we use here at Grady. Down here below what you're looking at are what we call hard keys. Those hard keys, they don't change their responsibility. And over here to the very far right as you're facing your console is an inspiratory hold button. Okay, so I press that inspiratory hold, and what I see here is a plateau of the volume. This patient's on assist control volume, or he's on SIMV, but he's breathing with his standard controlled breath. That's the breath that has the green up and the yellow down is a controlled breath. The breath with the red up and the yellow down is his spontaneous breath, but I can only measure it during a vent breath. So I press that expiratory hold. The ventilator actually makes the decision about closing the expiratory valves at peak flow, and we measure the plateau pressure. All I have to know how to do is be sure the patient's getting an assist control volume breath, and I need to know how to press that button. That's all I have to do. The vent does the rest. I don't have to time anything. I don't have to do anything else. And the ventilator is then going to display the PEEP plateau. So you can see my patient's PEEP plateau is 16. Remember, less than 25 is what we're shooting for, and we're pretty darn happy. Now, if your patient is only spontaneously breathing, you can't measure PEEP plateau. If you're on pressure control ventilation, you can't measure PEEP plateau. You're controlling the pressure. So they must be on an assist control, volume control breath when you press that inspiratory hold button. And the ventilator will close the exhalation valves on that assist control breath, trapping the gas, putting that gas across the functional lung. The smaller the functional lung, the higher the plateau pressure. That's straightforward. It's pretty straightforward. I feel pretty straightforward. Okay, so now let's just think about this as it relates to our patients, okay? So there's a very beautiful drawing from a wonderful article, which I'm happy to share with you, and I can post it in the chat box. Okay, so we just talk about opening pressure. So normal, you're at 0 centimeters of water pressure. But once you have some edema, and you can see this surface area here has edema, so that's fluid that's actually filling the alveoli and also compressing the alveoli, you actually need to open that with around 10 to 20 centimeters of water pressure. And alveolar collapse is going to be best opened with 30 to 40 centimeters of water pressure. And true consolidated alveoli are not going to be able to be opened. Okay, well, already this is pretty extraordinary. I've got to use a higher level of opening pressure of PEEP for edema and for collapsed lung, at least initially to open the lung, not necessarily to sustain them on ventilation, but to open up their lung. Okay, so really, really important for us to appreciate how this is drawn here, again, from the same article that looks at consolidation. I'm not going to be able to open the consolidated lung. That's got, you know, it's mucus with product, it's firm. I'm not really trying to open the consolidated lung. What I'm trying to always do is open the collapsed lung. And I want to open the collapsed lung without over-distending. Okay, so I am trying to open a collapsed lung without over-distending. And the way that's being recommended today, lots of research going on. I'm not telling you it's the absolute end all and be all, but the way it's being looked at today is that when you are actually opening the collapsed lung, you're going to see a decrease in the driving pressure. And just as simple as possible, drive pressure is PEEP plateau minus PEEP. So as I go up on my PEEP, if I see the gap between PEEP plateau and PEEP narrows, that means I've decreased the driving pressure, and that means I've opened the lung. Okay. When I talk about overdistension, what's going to happen is as you go up on PEEP and you are overdistending the lung, what you're going to see is PEEP plateau is going to go up, and the difference between PEEP plateau and PEEP is going to get wider. So the difference between PEEP plateau, which is that expiratory hold telling me about alveolar recruitment, minus PEEP, that actually gives me a simple way. It's not the only way, and it may not be the most scientific way, but from a bedside perspective, it's the simple way of looking at whether or not I've opened the alveoli. So I have a PEEP plateau pressure, let's say of 40, and I have a PEEP of 10, and that difference is 30. As I go up on the PEEP and I open up more alveoli, the difference between the two will get narrow. That's how I know I'm using PEEP correctly. I'm going to look at the drive pressure. Drive pressure, PEEP plateau minus PEEP, should get smaller once I've opened up the lung. This is how I choose PEEP. I don't just stand at the bedside and say, well, we're going to go up on PEEP by 2 centimeters. Hopefully it's going to work, right? I actually have a scientific framework for evaluating what kind of PEEP my patient is going to need. Now, this is a really fantastic visual from a highly respected pulmonologist, John Marini. And Marini has written multiple books on respiratory therapy and on pulmonary management, on ventilation, and really is an abundant resource in terms of looking at ventilator management of critically ill patients. But he's talking about when we have a non-compliant lung, what's going to happen as you actually increase your PEEP is that as you try to open that lung, you will actually see that this will be very well tolerated in that non-compliant lung. If you apply the same philosophy in the compliant lung, so let's say the top of the lung at the top, so at the apex, that's a very open lung, and at the base, that's a very collapsed lung, right? Our goal is to try to find a methodology that opens the collapsed lung without overdistending the open lung. That's what our goal is. That's the goal at the bedside. And it requires a very intricate evaluation, and it requires a lot of attention to detail in order to try to open the lung without causing overdistension. Now, the two things we do on our ventilator is we press over here. At the far right, we press an inspiratory pause, and right next to that would be an expiratory pause. The inspiratory pause gives us our PEEP plateau. Okay, so here's a patient who's on SIMV, but he has 12 vent breaths per minute. He's not breathing in this moment. Anyway, I can't see what his actual frequency is. It looks pretty high. But in this moment, because it's the green up and the yellow down, that's the assist control breath. I press the inspiratory hold, the exhalation valves close, we trap gas, and what we see is what the pressure is at primarily at the alveoli, and that is projected as the PEEP plateau pressure. Okay, so now I go up to the peak. Peak is 47. That's higher than 45. It's not that much higher than 45 though. But when I look at the PEEP plateau is 40, which is significantly higher than the goal of 25. And sometimes we even accept 30. It's still significantly higher than that, which tells you that you have de-recruited alveoli. Okay, now your patient is currently on 12 of PEEP. Okay. The next step that you might make, not necessarily here, but it's okay. The next step is I move from the inspiratory hold button, give the patient a couple of breaths now, right? Remember, the inspiratory hold just exists for one breath for one period of time, and then the ventilator opens the exhalation valves and the patient goes on to breathe in and out as regular. Next to the inspiratory hold button is the expiratory hold button. I press the expiratory hold button. What that does is it actually closes the inhalation valves, and it tells us about whether or not our patient is trapping his own gas in his alveoli. Now, trapping his own gas in his alveoli is performed during expiratory pause, and that is called auto-PEEP. Auto-PEEP means that the patient doesn't have enough time to exhale, has too much tidal volume to exhale, and he traps gas in his alveoli. And you might say, well, that sounds okay, because isn't that what we're trying to do? Trap some gas in the alveoli to maintain alveolar opening. And yes, indeed, you're absolutely right. That is what I'm trying to do. The difference is in the applied PEEP that I'm giving you from the ventilator, that's refreshed gas. So it's oxygen-rich gas. When you trap your own gas, you're trapping CO2-rich gas. So I always call that dirty gas. You're trapping dirty gas. I don't want you to auto-PEEP. In general, I don't want you to auto-PEEP. Now, auto-PEEP means, and this patient doesn't have any auto-PEEP, that's because you look here and it says intrinsic PEEP, I-PEEP, intrinsic or auto is 0. And the PEEP that I'm giving the patient is 12.5, and you can see that primarily he's getting PEEP at around 13. So he had a 0.5 of PEEP, which is insignificant. What that means is the patient gets his next breath, but we actually see the gas was trapped in the lung. And you see that here in this circuit. This is called the flow circuit. Flow does not come back to 0 before the next breath occurs. Doesn't matter how much PEEP you've applied. This is only about the patient's own gas trapping. So you can see right here, we're at a 0 line. Your patient's gas flow came back to 0 before his next breath. Sometimes it's way down here. Sometimes it's even farther down. And that means that the patient is trapping gas in the lung, and that's bad gas. That's dirty gas. Okay, so our purpose today is to really talk about PEEP plateau and to recognize that there are two things that we're going to do to treat the PEEP plateau pressure. PEEP plateau is high. The very first thing I'm going to do is I'm going to reduce your tidal volume. As I reduce your tidal volume, I might start to see some CO2 retention. So I'm going to increase your respiratory rate. As I increase your respiratory rate, I'm going to limit your time for exhalation. So then you may actually auto-PEEP. It's all yin and yang, my friends. And it's not like anybody said, this is the absolutely right way to do things. You have to trial and error and trial and error. And here's the thing. The therapist makes a change and they leave and you're still there at the bedside. That's why you need to be able to look at this. You need to be able to appreciate it. So as we reduce our tidal volume, so you'll see this patient's on 500 tidal volume, okay? So let's say we reduce the tidal volume to 400, right? Our PEEP plateau pressure is going to reduce because there's less volume going into the lung. As we have less volume going into the lung, we're going to see some CO2 retention. So naturally, folks are going to want to increase the patient's respiratory rate. And as we increase the respiratory rate, we're going to see an increase in the minute ventilation. That's over here, V with a dot over it, subset E tote. That's minute ventilation, the amount of volume you're moving over a minute's period of time. But as I increase your respiratory rate, because here you can see the respiratory rate's around 9.5, right? Okay. As I increase your respiratory rate, you're going to start to trap dirty gas. As you trap dirty gas, I now have to step back and say, uh-oh, I didn't give my patient enough time to exhale. It's really pretty simple. Breathe in, breathe out, time for exhalation. Breathe in, try to make sure all the gas that you're breathing in gets to the alveoli. You're going to do that by increasing the PEEP. But you're going to reduce the overdistension by reducing the volume. As you reduce the volume, your patient may retain CO2. So then you go up on the respiratory rate. And as you increase the respiratory rate, you're going to have less time for exhalation. So that's going to be all very important when we're taking a look at our patient. So now I'm going to go back to this graphic. I'm going to remind you, we want to have a peak pressure less than 45 and a PEEP plateau of less than 25. And now I want to instill here a PEEP. Okay, and I'm going to say the PEEP is 5. And then I'm going to say that my patient's plateau pressure, it's red, so it's correlating with that other plateau pressure is 35. So that means that normally it was 25 minus 5. That was a dry pressure of 20. That's already extraordinarily high. Now my plateau is 35. 35 minus 5, that's a dry pressure of 30. That's extraordinarily high. My goal, P plat minus PEEP, is that cutoff value of P plat minus PEEP, that's the drive pressure, should be less than 15 centimeters of water pressure for patients who have stiff lungs, okay? Every time a unit increases, that's just 1 centimeter of water pressure. So here, that is 30, right? Every time that increases, each degree it increases is correlated to a 5% increase in mortality. Okay, so let me just say this again. I have a high plateau and a low PEEP and a wide drive pressure. Plateau minus PEEP is drive pressure. I'd like that to be less than 15. Now, if you did a plateau on me, my plateau pressure would probably be 10. I'm not on any PEEP. I'm intubated, I'm on a ventilator, I'm not on any PEEP. I have a plateau pressure of 10. 10 minus 0 is 10. That's a nice functional drive pressure. I want to remember that when the lung is stiff, my PEEP plateau is going to go up. And what I have to do is consider, it's not the only thing, but I'm going to consider advocating for increasing the PEEP in order to narrow the drive pressure. Okay, so I'm going to just explain this in my very simplest Barbara terminology. And that is that if I'm driving hard to put volume into a stiff lung, that gradient is going to be wide. As I open the lung with PEEP, that gradient is going to get narrower because the lung is no longer so stiff because I've opened the alveoli by utilizing PEEP. So number one, I'm going to use the graphic, if I can, to look at low inflection point and over distension and try to set somewhere in between there. Number two, I'm going to look at P plateau. And when P plateau is elevated, I'm always going to consider administration of higher PEEP. So I start with my PEEP and then I say P plat minus PEEP is drive pressure. The stiffer the lung, the narrower the gradient of drive pressure I want to actually achieve. This is how we make choices about PEEP. We don't just say, we're going to go up on PEEP because we want to improve your gas exchange. We actually have to think about the stress and strain of the lung as it relates to tidal volume and as it relates to PEEP. Tidal volume and PEEP are what I'm going to adjust in order to achieve a drive pressure that actually opens the lung without overdistension. Okay, so now we're going to look at one of our patients. You can see here that you're seeing the P peak is 40, so it's right on the edge of acceptable. The P mean is 22, and the PEEP is 13. Okay, so now I have a P plateau of 36. 36 minus 13 is a drive pressure of 23. So I don't believe I've opened the lung as well as I could. So I might actually advocate to go up some on the PEEP, perhaps to 15. What I'm going to look at is, does my plateau pressure stay relatively around 36 as my PEEP goes up, which means I've opened up more lung and I have a narrower drive pressure. Now, the evidence on drive pressure and the formulary on drive pressure is not fully vetted or in any guidelines at this time, but I would tell you that all the original authors who looked at PEEP and alveolar recruitment and PEEP plateau pressure are saying this is not good enough. We've injured people's lungs. We have to look at something more. And what's being looked at now is drive pressure. P plat minus PEEP. The more narrow the drive pressure, the more open your lung. That's the point. The more narrow the drive pressure, the more open the lung. The stiffer the lung, the higher the drive pressure, the less the lung is open. And PEEP is about opening the lung. So that makes perfect sense. I hope. It seems like it makes perfect sense to me. Okay, so my PEEP's at 13. My plateau is 36. And here's where the plateau pressure was measured, where the gas was trapped at peak inspiratory pressure or peak inspiratory flow. And we've trapped the gas in the lung and looked at that gas as it's distributed across the whole airway circuit of the alveoli. Okay, so why is this so important? So when I look at these three correlates. Okay, so I'm looking at basically a patient here at low inflection point, which means the alveoli are collapsed. Remember, that's the low inflection point. I'm looking at a high P plateau pressure, and then I'm going to introduce PEEP. So if I have a high plateau pressure and I have a low PEEP, I'm going to have a wide drive pressure. I'm going to add more PEEP. I'm going to add more PEEP because what I want to do is open the collapsed alveoli. That's what I'm using PEEP for, to open the collapsed alveoli. And that's going to be PEEP typically greater than 8. Might be 10, might be 12, might be 14, might be 16. I'm going to add PEEP to open the alveoli. And while I add PEEP, the plateau pressure is going to go up. The PEEP has gone up, but the difference between the two, which is the drive pressure, has narrowed. So here, we're looking at all these patients are getting 6 mLs per kg. So we've already adjusted the tidal volume, but now I have well-expanded alveoli. Now, if I continue to go up, what's going to happen is I'm going to overdistend the alveoli. So again, when I look at that volume pressure graphic, I'm going to see that beak at the end. If I look at a chest x-ray, I'm going to see very highly aerated surface areas with still some small dysfunctional area. But what I want to do, and you can see here again, is so I've added that PEEP, but now my plateau has gone up even more because I've overdistended the lung. So again, my drive pressure is increased, and you can see that the best place is right here. Where the drive pressure is narrow, the relationship of P plat to PEEP is narrow, and it's told me that I've opened the lung. So what I would just say is just experience this. You're at the bedside, you've got patients on a ventilator. Look for a patient where the discussion is that the patient has a non-compliant lung or ARDS. Look at their P plateau, look at their PEEP, look at the drive pressure, talk with the therapist. If they increase the PEEP, look at what happens to the drive pressure. Now, as you increase PEEP, plateau is also going to go up, but the difference between the two should narrow. That's what's really critical, is narrowing the difference between the two, which means you have opened the lung. Fantastic. When you've opened the lung, if your patient is on SIMV, they're going to move more volume. When you've opened the lung, your patient's going to have better oxygen gas exchange, so you'll be able to reduce the FiO2. So we're going to look at that volume pressure scalar. We're going to look at the P plateau. We're going to look at the PEEP. We're going to look at the difference between the two. And when the difference gets narrowed, we're going to see that we're able to reduce the FiO2 and improve gas exchange. How fantastic is that? So again, from the same article, very beautiful visualization that reminds you that when you want to recruit your alveoli, and open them up, you're going to increase PEEP, right? So recruitable alveoli, non-recruitable alveoli, you're going to increase the PEEP. But when you increase the PEEP with recruitable alveoli, you will optimize and normally expand. If the alveoli are not recruitable and you've increased the PEEP, you will overdistend the functional alveoli. Now, you'll be able to see that because, by the way, your drive pressure here, when you've increased your PEEP, your drive pressure will narrow. Your drive pressure here, when you increase the PEEP and you're not able to recruit the alveoli, your drive pressure will widen. Oh my gosh, it's so fantastic. Okay, now once you've optimized your alveoli and they're open, now you're going to have to think about decreasing the tidal volume to decrease the plateau pressure. So I put you on a PEEP of 15, I've opened your alveoli, and now I'm going to decrease your tidal volume, which means your plateau pressure is going to start to come down. So it was 40 and now it's 35. I've come down again on your tidal volume, and now your plateau is 28 and your PEEP is 16. The difference is 8. And you've optimized with your ventilator. You've optimized the alveoli. You've opened them up. You've distended them without over distending and basically normally expanding and optimizing your alveoli. So really, really important for us to appreciate the two things that we're going to manipulate to recruit the lung and protect the lung. Tidal volume to protect, PEEP to recruit, drive pressure to tell us about the efficiency of our strategy. So always remind ourselves when we're thinking about this is when we are trying to optimize gas exchange, optimize your PaO2 in relationship to your FiO2. First and foremost, of course, you'll always go up on FiO2, but secondly, you're going to think about airway pressure strategies. How do I open your lung? I'm going to open your lung with my first steps by increasing your PEEP. But it isn't only the PEEP that's important. It's actually looking at PEEP plateau minus PEEP. And remember, as you go up on PEEP, your plateau pressure will also go up. But what you're looking for is the narrowing of the difference between the two, because that tells you that you have opened up the lung. So again, it's not just, okay, let's try 5, let's try 8, let's try 10, let's try 12. There is a strategy. We're always going to evaluate lung compliance. We're going to look at that scalar, right? The volume pressure scalar. That requires a lot of sophistication, but you should practice it. You should look at it. You should always ask your therapist to show it to you. Look at it together. Have them explain it to you. That's really important. You're going to look at PEEP plateau. You press the inspiratory hold. You're going to look at PEEP plateau minus PEEP, and you're going to drive that airway pressure difference between the two. You'd like to see that go down. You're going to drop PEEP plateau by reducing the tidal volume, and you're going to increase your PEEP, and you should see a narrowing of the drive pressure, which in the simplest of terms is PEEP plat minus PEEP. There are many more sophisticated ways, but for our purposes, what's simple to do at the bedside, what's been validated is PEEP plateau minus PEEP. Now, remember, this strategy isn't for everybody. This strategy is for the non-compliant lung that you're trying to open. It's absolutely essential when we talk about ARDS and failure of lung compliance. Might be important to look at with all kinds of invasive ventilation, but strategically always with ARDS. Going to target that tidal volume to less than 7, and you're going to get there primarily to get that plateau pressure down. You're going to go down on that tidal volume to 6, maybe to 5, maybe to 4. And you're going to use PEEP to increase alveolar opening. Remember that as you go down on tidal volume, your natural inclination will be to go up on the respiratory rate, but you've got to make sure that the patient has time to exhale. That's a discussion for another time, but it's very straightforward, because you always want to avoid auto PEEP. So again, with your therapist, say, I want to look at PEEP plateau. I want to look at auto PEEP. You're not comfortable with those hard buttons, that's okay. You can ask the therapist to show you. They're pretty busy, but they're going to be pretty excited when you ask that, because they like to show you what the ventilator can do. And they're going to be able to show that to you. Your respiratory therapists are already measuring this in your patients. All you need to do is ask them to show you, because they're already measuring it and documenting it in the flow sheet. They're already looking at this information. And it's so important and so incredibly valuable. So we just want to remind ourselves, we're going to look at PEEP and FiO2. Those are really adjusted in tandem to try to open the lung and provide better gas exchange. Always trying to improve the amount of volume that stays in the lung during expiration, because that keeps your alveoli open. It provides you with an effective compliance or a functional residual capacity, gas that stays in the lung during exhalation, keeping the lung open. The stiffer the lung, the harder you have to work to restore functional residual capacity. That's why you choose PEEP. That's why you have to really participate in this, because allowing patients to be functionally hypoxic with under-recruitment and failure of resuscitation actually goes on to lead to multi-organ deficits. And that's part of what we're looking at and part of our responsibility to try to assure that we are actually providing better lung function. So I'm now going to end this session in terms of recording, but I'm going to stay online in case there's any discussions. Thank you for attending today's Tuesday topic. I'm going to stop my recording. Thank you so much.